apart from that will be a sharing from one famous university. If you talk about in this region, of course, this university is one of the most well-known university. And apart from its beautiful campus, is also known for its research excellent and technological innovation, ladies and gentlemen. It is time that we are honored to learn under the topic of the design of pharmacogenomics implementation in a teaching hospital and in general practice clinics in Singapore. Of course, ladies and gentlemen, I am talking about Nanyang Technology University, or NTU, and it's our greatest honor and pleasure to have Dr. Michael Winther with us here.
Good afternoon. I'm delighted to be joining you from Singapore for the 9th Annual CPharm Conference. This is the 7th meeting I've been able to attend for CPharm since 2014, and it's been wonderful to see the growth of science across the region as we work together to bring the research into clinical implementation. So I'd like to thank the organizers for inviting me to speak today, because I have the opportunity to present updates on two very exciting studies we're doing to take implementation into the two very different settings of a large public hospital and in general practice clinics. I would like to begin by providing some background as to why pharmacogenomics can be an important tool for reducing healthcare costs. The Pharmacovigilance Group at the Health Science Authority collects data from across the country on reported adverse events from drugs. This information can come from public hospitals, polyclinics, private hospitals, and is compiled into an annual report that in 2019 showed over 37,000 adverse events. This graph on the right shows the different drugs which are reported and how frequently the adverse events are reported. You'll see that the two general classes causing a large number of the reports are the NSAIDs and the antibiotics. But other drugs are also associated with AEs, and this information gives us a very good snapshot of where the adverse event issues might be in Singapore. We'll note that the reports are primarily from public hospitals and polyclinics, and this reflects the fact that the adverse events are usually identified in the hospitals, but it doesn't tell us where the drugs are prescribed. In fact, there's a lot of information that you can't obtain from these reports, so this information alone is not sufficient for us to be able to design the type of implementation studies required to make pharmacogenomics a routine tool in medical practice. So how can we fill that gap? To fill this gap, we conducted a prospective adverse drug response study at the Singapore General Hospital. This study involved observation of 1,000 patients admitted to ward over a period of 1 month. We found that 12% of the hospitalizations were accompanied by an adverse drug response at admission. And for 81 of the 1,000 patients, that was the reason why they were admitted to hospital, and an estimated cost of $788,000 of in-hospital expenses for treating that ADR. Extrapolated across the country, this would be equivalent to $368 million of expenses in hospital for treating preventable ADRs. The role for pharmacogenomics in reducing these ADRs was identified because 30 of the admissions were caused by ADRs for which there is a pharmacogenomic drug-gene association. Those 30 admissions alone were almost $300,000, which extrapolated across Singapore would be an annual preventable healthcare cost of $123 million. This sets a target for our adverse drug response implementation plans to reduce that cost. I think we would all agree that there's a very clear case for using pharmacogenomics to reduce adverse drug response. The research is pretty clear and extensive over the past few decades, but currently there is relatively little clinical implementation, certainly in routine practice. What are the barriers to implementation? We'll discuss a few of those now. I think that most groups looking to pursue clinical implementation will come across a set of common barriers. Three of these that we've identified are relevant to the discussions today. First of all, we need to really aim to build a sustainable system that brings genomics into routine medical care, not just in the context of a research study. Secondly, we need to ensure that the guidance that is provided to patients is relevant to the regional populations. And thirdly, we need to take pharmacogenomics to the local community and not just the large teaching hospitals. We'll touch on all three of these issues now. Clinical implementation systems can be quite complex. I find it helpful to look at this as a series of building blocks that are assembled together to create a functional process. The 6 building blocks or modules that I summarize in this slide are a helpful context for looking at the design of the implementation studies that we'll be describing. All 6 of these have to be addressed in any complete plan. To start with, is the research a clinical trial, or is this actually a standard of care implementation? There's different frameworks for the different types of studies to be considered. Secondly, where will the study take place? Are these only in the large teaching hospitals, or would we try to include general practice clinics and polyclinics? Thirdly, what technology to use? This is a fast developing field, and whatever technology we choose today could well be replaced in a few years' time by something more accurate and less expensive. But at this stage, a wide variety of methods are used, from whole genome sequencing to PCR, microarray, etc. All of these need to be considered and looked at from both a cost and quality point of view. Fourthly, there's the system for storing genomic data and the dosing guidelines, part of the clinical decision support system. If this is a large hospital, it's likely to have an electronic medical record system that can be adapted for this purpose. But a different system will be required for the more physically dispersed general practice clinics. A fifth aspect is having guidelines to follow. CPIC provides one set, but we might need something more appropriate for the region that we live in. And finally, who is dispensing the medication? If it is a large hospital, there'd be a dedicated pharmacy. But in GP clinics, the GPs and their staff provide the drugs in most cases. So we need to be able to reach all these different groups. These 6 modules will be different for every study that we would be looking at. The 6 modules we just discussed can be assembled into some complex machine shown in this illustration, which takes patient information in and dispenses outward a personalized drug prescription. Ideally, this process will be essentially invisible to the patient, and in some cases might even be relatively opaque to the clinicians using the information, but to those developing the system, all the components have to fit together so it can function as one machine. The goal for this machine is that we have an economically sustainable system, so that the cost of running the machine is actually less than the benefit derived by running it. In other words, the savings from reduced ATRs should be greater than the cost of the PGX services. It sounds simple in principle, but both of these are rather challenging. First of all, estimating the cost for running the system. But even more challenging is to actually understand exactly what the savings are from reduced adverse drug responses, as this is likely to require a large clinical study run over several years in order to get quantitative information on the cost of the ADRs and how much money can be saved by reducing the ADRs. The Europeans are doing such a study called UPGX at a cost of 15 million euro and spanning over 4 or 5 years. That information was considered essential for an implementation system in Europe, and it sets a standard for other groups to consider following. The second area I wish to discuss today is making pharmacogenomic guidance relevant to regional populations. CPIC and the Dutch Working Group have developed excellent peer-reviewed guidelines that are published and regularly updated. However, the data that drives these guidelines has an underrepresentation of genomic and ADR information from Asian populations. We need to fill that gap so that we can actually support more effectively precision medicine implementation. There are already a number of national initiatives underway developing genomic information for this purpose. I note a few countries, Singapore, Thailand, Vietnam, Brunei, and others, where this is happening. And over the next few years, they will likely fill this gap. But for implementation programs that we're planning now, well, we will rely on CPIC and the Dutch guidelines where appropriate, and we can supplement that with local information as it's available. The information from these national genomic initiatives can then be channeled towards developing regional guidelines for pharmacogenomics. This will allow us to move beyond CPIC and develop our own guidelines used on information gathered from this part of the world. These guidelines can reflect the different countries, the genetic compositions, and also the different medical practices, what drugs are available, how they're used. The local guidelines will require significant resources to develop, and I think it may introduce a delay in many of the current implementation programs unless they just choose to default to using CPIC recommendations. It's likely that each nation will have its own unique features in how these guidelines are developed, but I think across the region there are enough common features to make an Asian approach quite useful for us to consider and economically beneficial so that each country doesn't have to do the entire task on their own. We've discussed previously the idea that CPharm could help bring together a consortium from across the region and develop our own APIC as an analog to CPIC and what the Dutch Working Group is doing across Europe. This would be a goal for us to discuss over the next few days. This brings us to the third barrier, which is bringing pharmacogenomics to the local community, bridging the gap between research and implementation. As we know, most research takes place in teaching hospitals with highly trained staff, excellent facilities. This is where researchers move forward. However, implementation needs to take place wherever drugs are being prescribed. And to a large extent, this happens in general practice clinics in Singapore, where the clinician will not only diagnose, but also provide a prescription and dispensing of pharmaceuticals from the GP clinic. We need to bring pharmacogenomics to this very different environment. A brief summary of medical care facilities will illustrate this point. The table shows key features for a range of institutions providing medical care: public hospitals, private, polyclinics, and GP practice. Whereas there's around 10 large public hospitals in Singapore, those will be the source for the early implementation research studies. The GP practice is quite different. There's over 1,600 GP clinics in Singapore. The public hospitals have specialized pharmacies, molecular diagnostics, and critically, they have electronic medical records which are now gathering information within the institution, and as we mentioned earlier, can be used for holding genomic information and drug dosing guidelines. However, not all GPs can link up to such sophisticated EMR systems, and we need to find another way to store and deliver genomic information to guide drug prescriptions in the general practice environment. Furthermore, there are unlikely to be any staff trained in pharmacogenomics in the GP clinics, so we need to be able to provide information and support for any implementation programs that are planned. The National University Hospital in Singapore is one of the larger institutions providing medical care, research, and medical training. They've recently incorporated a new electronic medical record system based on Epic, so they have all the tools that we just discussed that are needed in order to do a pharmacogenomics implementation. As part of the National Precision Medicine Initiative in Singapore, the NUH is implementing a pharmacogenomics panel that will be used for deriving SNP information and supplemented by additional tests for copy number variation and HLA alleles. This information can be incorporated into the electronic medical records and then accessed by researchers, but also by clinicians who are looking for treatment of patients. The hospital is currently preparing drug dosing guidelines in the mode of best practice alerts by reviewing all the current literature and providing the local NUH version of the guidelines to be followed for each of the drugs that are on the drug dosing list. Because we're in the environment of an electronic health record, which also collects economic data during the patients while they are in hospital, or even when they're outpatients for the various treatments they're experiencing, this information can be gathered together and we can provide an estimate of savings and taking this into context of real-world evidence. For application of pharmacogenomics in the general practice clinic, we've had to relook at each of the modules to see how they can be practically applied in the very different environment of a GP clinic. This covers all stages of the process. The initial sample collection, for example, would be based on the very convenient cheek swab process, and the samples analyzed by GSA array, which gives us rather inexpensive and fast turnaround time for getting the SNP information. This can then be uploaded to a cloud-based system with coded patient identifiers, and then run through a rules-based system for drug dosing guidance based on CPIC guidelines, and in this case, the system has been provided courtesy of Genexus in Canada. The guidelines can then be accessed by the clinician, and if there's an actionable genotyping biomarker identified, they can then consider changing the dosing of the drug that they might have otherwise been considering. At the end of this clinical study, Professor Helen Smith, the PI, will lead an investigation of how these guidance are deployed and what the GPs think about working with such a system, so we can fine-tune the operational running of such an implementation, enable us to then translate this from what is a 200 patient study to a multi-thousand patient study so we can track clinical outcomes as well as operational outcomes. Nevertheless, we see this study as a key part of moving from the hospital into the clinic so that people can access more readily this valuable genomic guidance. This slide summarizes the two implementation programs I just discussed. The modules that were assembled for each one of these systems is appropriate to the context and circumstances where the genomic guided dosing is being implemented. Both of these systems are likely to be evolving over the coming years, and the approach of looking at this as a series of modules allows us to have flexibility so that new modules can be inserted, but overall the productive features of the process can be maintained, and in that way we can gradually and continually develop more efficient and more effective systems that are appropriate for the location for the drug prescription process. Most of our countries are experiencing aging populations and rising healthcare costs. Moving more medical care from hospitals to GPs is seen as one way to have a more effective and less expensive healthcare system. One of the goals that we have set is to ensure that pharmacogenomics can be part of this movement and can be located where it's needed in the GP clinic as well as the teaching hospitals. Thank you for your time and attention today. I look forward to seeing you again at the next CPHAR meeting. And if there's an opportunity to answer questions, I'll be happy to do that. Thank you very much.
Ladies and gentlemen, as I mentioned earlier, that each and every of your participation will be highly appreciated. That is the reason why we would like to take each and every question from the audience out there to be answered nicely and completely by the speaker. And that is the reason that we would like to bring you back to the topic of the design of pharmacogenomics implementation in a teaching hospital and in general practice clinics in Singapore. And we will have Dr. Michael Winther to answer all the questions accordingly. The first question is very interesting. It is during the pharmacogenomics implementation into routine practice, how can we improve reimbursement schemes in a country with resource limited settings? That's the first question.
Okay, thank you. So I will answer the first. Too early? I, um, I'm happy to be back for the Q&A time, and I know there were a few questions that were put to me after that, and so I wasn't able to join immediately after the presentation. So the first question really had to do with the making the implementation effective for a reimbursement program. So I'm not an expert on the reimbursement issues, but I know there's two factors which I mentioned in my presentation that we can address. And the first is making the service economic. And that's very critical for us to have a service that we can afford. And the second part is to have good data on the economic savings that will result from that. And we need very large clinical studies to do that, to get enough information for the results and to see the benefits that we get. So that's why the Europeans have banded together for a very substantial study across 8 countries and over 8,000 patients in order to get this information. I think that will need to be a nationwide initiative for us to do that. So those are the two aspects that I would like to note.
Thank you very much. We also have the second question, which is revolving around expertise and information. So the question is, how can a hospital with limited genomics expertise and clinical informatics support implement pharmacogenomics ZDS?
Yes, that's a really good question because even the large teaching hospitals that I have been working with, they'll have some information of the domains where they have experience, but nobody has the full experience. And so everybody needs to help each other to get that. This issue is even more acute in the general practice clinics because clearly when you have a GP or a small group of GPs in a clinic, none of them have had the professional experience doing pharmacogenomic implementation, but they have to provide the test, they have to help the patient with the interpretation of the information that might change their dosing, and they have to make sure they can actually deal with the alternate drugs or alternate drug dosing that's handled. So the general practice implementation, which is the part I've been focusing on in the last year, is probably the most challenging for a number of reasons that you've just identified. And we're going to try and make progress by having online information systems that can back up any of the different dosing recommendations. And this information will be tailored for both the general practitioner as well as the patient. So we need to have quite a variety of informations coming in. And again, I think this would be something that many institutions could work on together so that as Dr. Go was speaking earlier at TTSH, she is developing a lot of those guidelines within TTSH. And she knows, as we all know, that we need to help each other more in this regard. So it's doable. And it's going to require more online access and perhaps real-time counseling access as well.
Thank you very much. That's very clear. And the last question is very important because it's not only talking about the practitioner itself only, but we are focusing on the patient side. The question is, how can everyone afford pharmacogenomic guided therapy in Singapore after full implementation into routine clinical care?
Okay, yeah, that's a very good question because in Singapore people do I mean, you can get support for healthcare, but usually, in many cases, people have to pay for certain activities themselves. If you look at the number that I gave earlier in my slides of $123 million saved, you could argue that for a population of 5 million, that's around $25 per person per year. So that's the potential savings. That doesn't sound so much when you put it that way, but but of course, if you look at the individual cases, in particular if it's a severe ADR, people would, I think, be a little happier to pay some money just simply to prevent the likelihood of that. It's a bit like having an insurance policy. So the way I see this potentially happening is that it may be a separate expense, but I could see this being included in people's various insurance top-up policies so that you could get this extra coverage within the insurance, and they could perhaps help, the coordination and get the benefit of scale. It really has to be inexpensive. It's why I was pushing for our first study to use the GSA ray, microarray. That's not a technology that people would normally use for clinical implementation. You see it's described as for research use only. But it has the potential for being validatable technology in the clinic. And again, working together, that might be a goal that we could achieve once we could identify the best platform that everybody would want to use, and then invest the effort into it collectively so that we could have a system that the genomic cost could be less than $100 per patient. Then you'd have some costs on top of that for the system. If you could get the total cost of the package below $250 or $300, it will be much less of an obstacle. And I think people could see the benefit of both reducing ADRs and having a better chance for the drugs being dosed correctly from an efficacy point of view.